Hello everyone, my name is Dr. Pradeep Shinoy from Pacespro. In line with our lecture series on MRCP Part 1 preparation, today we'll be discussing about opportunistic infection in HIV. The most common opportunistic infection which affects the eye is the CMV retinitis. Cytomegalovirus belongs to herpes group of virus. It is the most common opportunistic infection. It's commonly seen in patients who are with advanced HIV disease, such as those with a very high viral load or those with a very low CD4 count, specifically CD4 count of less than 50. The patient might complain blurring of vision or floaters. Floaters are mobile dot-like things in the visual field, or in a progressive disease, the patient can present with permanent visual loss. If you look at the fundus might show a characteristic pizza pie or a cottage cheese appearance. If you look at the fundus in this slide, you will see a lot of perivascular infiltrates. So the infiltrates are around the vessel, so that indicates that the patient has an significant HIV illness along with CMV retinitis. Then we have Corpus sarcoma. Corpus sarcoma can present as a tumor. It is secondary to human herpes virus 8. It's again seen in advanced HIV illness. There are basically two forms of Corpus sarcoma. One is called what is called endemic form, which is more common in African continent. One is the Corpus sarcoma, which is associated with HIV. It can manifest over the skin or in the internal organs. More common is on the skin, where it presents as a purple papule or a plaque over the skin or in the mucosa. These lesions can increase rapidly and they can ulcerate. If the lesion involves the respiratory tract, the patient can present with massive hemoptysis or a pleural effusion, which could be hemorrhagic. The patient is treated with improving its immune status by providing antiretroviral therapy, and few of the internal lesion we can offer radiotherapy or a surgical resection. The most important opportunistic infection for the lung is the Pneumocystis carinii pneumonia. Now it's renamed as Pneumocystis jirovecii pneumonia. It's basically a fungal infection by its genetic nature. The patient infected with Pneumocystis jirovecii will present as exertional dyspnea. Most importantly, they'll have a dry cough and a low-grade fever. If you do a clinical examination, you may not find any visible clinical signs. Or the key in the history is the exercise-induced desaturation. So that's a key point you should look whenever you read the question stem for part 1 exam. And the investigation, you can do a chest x-ray, which could be normal, or patient might have paracardiac infiltrate. If you do an bronchoscopy and bronchoalveolar lavage, you can see the organisms, which is specifically stained with silver stain. And another important thing is PCP is also seen in other immunocompromised conditions such as Cushing's disease. How do you treat? The drug of choice is cotrimoxazole, which is a combination of sulfamethoxazole and trimethoprim. If the patient is allergic to sulfa drugs, then probably you can use intravenous pentamidine. More importantly, if the person is hypoxic, where the partial pressure for oxygen is less than 9.3 kilopascal, you can supplement them with the steroids, preferably parenteral steroids. The benefit of giving steroid is that it decreases the respiratory failure by about 50% and death by about 1/3. And remember that all patients with the CD4 count of less than 200 should receive Pneumocystis carinii prophylaxis with cotrimoxazole. With this, we'll come to the end of this lecture. Thank you.